Okay, let's talk about abnormal uterine bleeding. Feel free to interrupt me if you have a question. I also have the chat box here. So abnormal uterine bleeding basically refers to uterine bleeding, or not just uterine bleeding, but really any bleeding in the context of the non-pregnant patient. And that's pretty much the entirety of your GYN modules, but in addition to what you'll need to know for your exam as well. Foundationally, it's really just important to know that where the cause of the bleeding is for the female patient, meaning that is it driven by dysfunction of the ovary, or is it the uterus itself? It seems simple, but it can be confusing. So really that's a bulk of what I'm going to highlight today. This isn't the first time you've heard of this. When it comes to abnormal uterine bleeding, it's very much in reference to your menstrual cycle. So that's probably one of the most important historical items that you'll ask a patient. Even if they don't really know what their menstrual cycle is, even that information itself is of importance, as you'll see. So in terms of what's normal for a menstrual cycle is that it generally should be about, the flow itself is for about 5 days, and the whole entire cycle lasts about 21 to 35 days, so about a month. There are traditional sort of terms that have been used, including menorrhagia, which is heavier bleeding. Metrorrhagia is bleeding between periods. Polymenorrhea is meaning you have more than one period, and oligomenorrhea means that you have a shortened period. But that's confusing for OBGYNs, let alone other specialties, to really understand. So it's preferred to just use plain terminology. Heavy menstrual bleeding is what is now the official term, okay? But the most important thing to remember is that it's the patient's perception of if something is heavy or not, which makes a difference. They used to say if it's greater than 80 mLs, because that's, when they were originally characterizing this thing, they were actually measuring it. But a patient who has heavy periods anyway may say, oh, well, this is heavier. That's important for us to be aware of. So patient's perception is important. And this is something that's not just anecdotal. It's endorsed by ACOG and pretty much any authoritative GYN resource. So this actually comes out of our practice bulletin. I'm not really one for mnemonics, but this is what is recommended by ACOG, so it behooves us to look at it. The terminologies that are actually used are simply abnormal uterine bleeding, okay? And then you have a fork in the road to determine what are the main causes. And this is the most important part. So first, it's either a structural cause or a non-structural cause. But when we say structural causes, this is being referred in the context of the uterus, okay, or the uterine corpus, I should say, the structure of the uterus itself. Non-structural causes, this is primarily where you get your ovulatory dysfunction. So as such, the ovary, problems with the ovary or the ovary itself, or systems in which affect the ovarian function, which is really your endocrine system, your hypothalamus pituitary ovarian axis, or your HPO axis, okay? That's what it's referring to. So for structural causes, what is the main diagnostic tool you have to determine this? Well, that's your imaging, your diagnostic imaging modalities, okay? Because that's going to tell you if you have a fibroid or a polyp, what have you, okay? Obviously, a physical exam as well, but you're not going to be able to detect an endometrial polyp on a physical exam, right? So you have your endometrial polyps, your leiomyomas, which are fibroids. These can be subdivided, but this terminology is not commonly used in medical practice, the AUBL, SM, or whatever. Leiomyoma, AUBL is what's used. Endometrial hyperplasia is a structural cause that cause abnormal uterine bleeding, but I can't say that I've ever seen this AUBM term used. Adenomyosis is endometriosis of the myometrial wall. So this is essentially endometriosis for all intents and purposes. Now, what do you see on ultrasound for adenomyosis?
A symmetrically enlarged uterus.
Yeah, I mean, you'll see an enlarged uterus for sure. It'll be large and it won't have any discrete lesions, correct? So that'll give you a hint you're probably dealing with adenomyosis. Usually what that means is on ultrasound, you'll see, say if there's obviously a non-pregnant patient, she has a uterine size that is bigger than normal. Your normal is about like 6 to 8 cm in the non-pregnant patient or postmenopausal patient. Sometimes you'll see a uterus that's about 10, 11, 12, but there's no discrete lesions. That's when you want to suspect adenomyosis. While it's endometriosis, you don't really have any discrete lesions that you see, at least on the ultrasound. Do you know what you'll see if, say, you have a laparoscopy or laparotomy? Sometimes you even see this a ton of cesarean delivery, what findings are for adenomyosis, not just your increased size. What you see is you'll see these like sub-centimeter cysts that they usually look yellow. You'll see that for endometriosis too in other places, but generally when you see that on the corpus of the uterus, that's also your indication of adenomyosis, and that the tissue is very friable, meaning that when you touch it, it kind of bleeds without much provocation. So those are all causes of abnormal uterine bleeding. But with your structural causes, if it's only a structural cause, you're going to have a normal periods, okay? You're going to have a normal menstrual cycle. Because it has nothing to do with your ovarian system. Keep in mind, the driver of the cycles themselves is the ovary, because it's all hormonally driven, and we'll review the menstrual cycle for like, the umpteenth time, but it takes a bunch of times to actually get it straight. So if a patient comes to you and says, hey, well, I'm having really heavy periods, especially if they've landed themselves in the hospital needing a blood transfusion because of it, you ask, do you have regular cycles? And they'll say, yeah, because their bleeding is due to the fact that they have fibroids, polyps, whatever. It has nothing to do with the actual cycling, but sometimes you could have both. With your ovulatory dysfunction, which is your non-structural cause, you're not usually dealing with any of this. You're dealing with ovulatory dysfunction, AUBO, which has to do with the ovary. You may have a coagulopathy, but there are ways to determine that, and they're pretty obvious. What may not be so obvious is that you're having abnormal bleeding, and it can be heavy bleeding because the ovary is just not cycling. So why is it that if you don't have a cycling ovary, why does that result in heavy bleeding? You would say, well, why doesn't that just mean you won't have anything? The answer, as we'll get into, is it has to do with the imbalance that you get as a result of abnormal menstrual cycles in terms of timing causes inappropriate buildup of certain stages of the endometrium, and then that just begins to bleed, and then that's hard to stop, actually. So we'll discuss that a little bit more, but just to give you this is your broad strokes overview. If you have a good understanding of this slide pretty much, and you understand where these come from and how to diagnose a structural versus non-structural cause and really the foundation of where these things come from, you're already in a really good spot. That's really all you'll need to know for your exam. You go into OBGYN, you'll need to know further nuances, which will be well set for your intern year. But your non-structural causes, instead of being diagnosed primarily by imaging modalities, here it's laboratory values, basically looking for abnormalities in the endocrine system and also the ovary itself, which we'll get into. In terms of structural abnormalities, uterine leiomyomas, also known as fibroids, are extremely common and the most common cause of abnormal uterine bleeding, especially heavy and prolonged bleeding, leading to iron deficiency anemia. They're extremely common. About 80% of Black race women will have uterine leiomyomas by age 50, but also even 70% of white race women. So it's extremely common, okay? Now, to the point where they'll actually need a surgical intervention is a different story. But oftentimes we see something that looks like this, where we have a uterus and it's just socked full of all of these fibroids, okay? They can be classified as subserosal, meaning that it's under the serosa, the outer part here, because you have your myometrial wall, which is here, and then the thin layer on the top is your serosa. Then you have your endometrial cavity itself, for which it could be fibroids as well. Fibroids could be anywhere, you know. You could have fibroids in the cervix, like this. You could have fibroids in the broad ligament, which are free. You could have fibroids really anywhere. You could have submucosal fibroids, which are in the actual cavity itself, which this would be an example of. And intramural is when it's only in the myometrial wall. So that's an example here. Pedunculated, meaning that it's on a stalk. So sometimes you have a subserosal pedunculated fibroid that looks like this, right? Because you have a stalk here. That could also be in the cavity. Then you have a pedunculated subserosal. There's not a simple, ineffective, and safe long-term medical treatment. So that's why these things are still managed surgically. There is a classification, a subclassification system for leiomyomas. You don't need to memorize this by any means, but even, especially like when I do surgery, it's good to use the system because reading it's very obvious what it is. Now, nothing is, well, I would say fibroids are not always one thing uniquely. So for example, you see this picture on the right where you're identifying the different stages. So stage 0 that's an example of your pedunculated submucosal fibroid here. And stage 1 and 2 are examples that are mentioned here. So these are subserosal. But you may have, fibroids that span the gamut of these numbers, and then they're just hyphenated like this, okay? You could have a fibroid, say, is in your endometrial cavity, but then it extends all the way subserosal like this, which is pretty common. This would actually be like a 2 to 6 almost, but it's not important for you to know, but just know that fibroids have different locations, okay? And what is important about the location is not necessarily the nomenclature, but the symptoms they cause. So if you have a stage 6 fibroid here, what symptoms do you think a woman is going to complain most about? She'll probably complain more about bulk symptoms, meaning that things like early satiety, urinary frequency, etc., because this rock is pushing up on everything. I had a patient who she had one big fibroid. Say if this is posterior, this is anterior, and what it looked like, it was this. Right? It was a big pedunculated fibroid. It was about 6 centimeters. And then her main complaint was urinary frequency, because this one is just smushing the poor bladder that is anterior here. So you just performed a myomectomy and then all the symptoms went away. So as opposed to, say, you have a bunch of these type of fibroids, stage 0, 2, 1, or even 3, because it does touch the endometrium. See, stage 3 is it contacts the endometrium. What are those symptoms going to be like?
More so around menses.
Right, bleeding. They're going to bleed. They'll have pain, of course, but it's going to very much be bleeding. The good thing about these is they can be managed hysteroscopically, so you don't make an incision at all, as I'll show you. So very good. And then 8, you could have cervical fibroids that just like big in the cervix, which is a little troublesome because the ureter course is about 1.5 centimeters to the internal os, so you got to be careful. But that's pretty much the long and short of that. An endometrial polyp, and we'll get into treatments, of course. An endometrial polyp is it's a hyperplastic growth of the endometrium. So by definition, it can only be in the endometrium. And that can be a source of bleeding and cramping. Do you know why that is? Why it causes why does it cause pain? They're not that big.
There's a lot of vascularity on it.
Well, yeah, it's definitely vascular. It has increased vascularity, and that's how it's determined. But why is it painful? That's why it causes bleeding.
It triggers contractility.
Yeah, yeah, exactly. Because it's hanging down in the cavity, the uterus tries to push it out more or less, and it can't because it's attached. So it causes cramping. Exactly. So it causes the uterus to contract. Very good. So, and it's hypervascular, so it bleeds every time that happens. And that, if you have quite a bit of them, it'll cause a lot of bleeding. And then when you have your menstrual cycle, when this tissue turns over, it doesn't have enough of an activity to be completely dislodged. But what happens is that it'll have heavier bleeding. So this is an example of what it looks like on ultrasound. So if you're not familiar with how these ultrasounds look, this might be a good opportunity to review that. So this is your uterine corpus, right? If I decided to kind of cut it in half and look inside of it, almost like how you might do with a fruit, that's what we're doing here. So this is our cavity proper. And what you can see is that you have the beginning of what your trilaminar disc is supposed to be. And then you have this big mass. It's pretty dramatic, but it's not actually all that big. I mean, here, if you look, it's only about 3 centimeters, right? But you have a big polyp there. What you'll see is even if it's thickened, it'll describe it on ultrasound as like a hypervascular, a discrete mass with increased hypervascularity, suspicious of polyp, right? Sorry. So that's what you're looking for. Here's a better image. So these polyps will hang down here. This almost looks like a fibroid, but it can look like that. And this is an actual hysteroscopic image to your right. The uterus will try to contract to push this out. And that's where your pain results. Here, you'll see the hypervascularity here like that, and it comes off of the wall. And actually, if you could tell, it is increased tissue here, but otherwise this is pretty normal except for this. So if you haven't seen this already on your rotations, I had a case the other day where we used something called a MyoSure, but it's an instrument that essentially it's a hysteroscopic instrument that you go in and you can sequentially shear this thing off. It looks kind of like a mechanism that almost eats, and I think I have a video of it in this. But that's how you manage it. And then the response is very good. Afterwards, the patient feels much better. Now, endometrial polyps can grow for a bunch of different reasons. They're estrogen responsive, so they can be seen just as a normal response. But sometimes, say if you have a patient, she's postmenopausal, but she's on hormone replacement therapy, she'll grow more polyps. It's not the end of the world, but that is something that is expected. So that's where they come from. Even obese patients, even if they're postmenopausal, they'll develop polyps and have potentially abnormal uterine bleeding because of that. Do you know, now that we're talking about obesity, the 3 types of estrogen, where they come from? I sort of gave you the first one, right? So E1 is estrone, okay? And that comes from the peripheral adipose tissue, okay? And then we have estradiol, which is E2. And that comes, that's like your actual estrogen that comes from the ovaries, okay? And then you have estriol. Do you know where that comes from? What that is? Think about it. Where have you seen that before? You saw this in your prenatal screening, right? It comes from the placenta. So that's what we use in our quad screen. That's trial. Okay. So if you have patients postmenopausal, but she's obese, well, you got a lot of this, which means that you can get polyps. And estradiol is what we have in our, that's why estradiol is in your birth control pills, right? That's why you don't have estrone or estriol, because that's just not what's made. And then this is used, if you have some abnormalities in the placenta, you'll have, well, if you have genetic abnormalities, I should say, this value, the estriol will be abnormal. That's why it's used. Okay. So how do we manage these things? Medical management, the bottom line is that for structural abnormalities, there aren't great medical treatments, as I mentioned. What is plausible to try is you can use your levonorgestrel IUD system. I have Mirena here, but there are others like Liletta and Skyla and all those other funny names. But basically, it's levonorgestrel or some sort of progesterone. They don't all use this levonorgestrel, but it's progesterone IUD. Okay. Should have attached my little drawing tablet. There are GnRH agonists, which is Lupron, which you can use. And there are GnRH antagonists, but they're not really used very well. They're not too standard to use for management of fibroids anyway. They're used in the management of endometriosis. And then you have your anti-fibrinolytic agents, which is tranexamic acid, which goes by the brand name Lysteta. Levonorgestrel IUDs, there's no randomized trials looking at their use, but for heavy menstrual bleeding as it's related to uterine leiomyomas, there are observational studies and systematic reviews that show that it helps a little bit. If you have an intercavitary leiomyoma, meaning like a submucous myoma or whatever, and you can't actually use the IUD, that's a contraindication. Sometimes women who don't want to have surgery, you can try this, but it oftentimes is very much on a, it's not recommended, and it doesn't really work all that well, because if you can appreciate that your leiomyomas, for example, if you look back on this image on the right, or even here, progesterone is used to stabilize the endometrium with the understanding that you have an inappropriate increase in estrogen. You have an unopposed estrogen problem. So that's why the IUD works, because it's providing progesterone as a balance. If you have fibroids here, and that's causing your heavy bleeding, you're trying to strike a balance where it's frankly not even a balance issue doesn't really work, okay? That being said, if someone doesn't want surgery, but they want an answer, sometimes it's tried, but honestly, it's not a good treatment, and that's why it's not indicated for that purpose. GnRH agonists work very well, because the bottom line is that the GnRH agonist, by a positive feedback mechanism, you see in the diagram on the right, shuts down the ovary. So you, for all intents and purposes, go into menopause. It's the most effective medical therapy because these leiomyomas are estrogen responsive, for good or for bad. So because you're basically establishing a clinical menopause state, you're not having periods at all. Most women develop amenorrhea, so you have an improvement in your anemia and the fibroids shrink. However, then you have all the problems of going into menopause, which are pretty significant. And that includes sleep disturbances, hot flashes, impaired mood, vaginal dryness, etc. And then once you stop it, the Lupron, it goes right back. There's rapid resumption of menses, which is good, but also pre-treatment uterine volume. So it's used in a couple of contexts. It's not that it's just it doesn't work and that's it. You could selectively use it as preoperative therapy. Say you have a woman who's in her 30s and she desires future fertility, but she's never been pregnant before. Sometimes you'll see they'll have very, very large fibroids, right? Causing pain, bleeding, what have you. You could put them on Lupron for a month and then do surgery. That'll reduce the fibroid significantly. And then when you do your abdominal myomectomy, it's less risky and you have a greater chance of success. Additionally, it could be used to manage complicated endometriosis. Because sometimes what you do is you could have endometrial deposits anywhere. This is an example on the right, which is something called catamenial endometriosis, which is endometriosis of the lung. Okay, and these implants are really troublesome because when you have your menstrual cycle, they also cycle, so they hemorrhage, and you hemorrhage into your lung. You have to have a lot of VATS procedures, and it's actually a very morbid and terrible thing. So why don't you just do a total hysterectomy, right? With oophorectomy. Why don't you do that? You would think that would work, right? Get rid of the problem. Do you know why it doesn't work? Well, do you know why it's not performed, I should say? Sort of by the same reason we were talking about. You still have estrone, right? You still have E1. If I take away your ovaries, it may help, but if the study they conducted those studies and it's not a slam dunk, and sometimes it doesn't work. In which case, you put the patient into clinical menopause, which we know by the Women's Health Study. If I take away your ovaries now, you're going to have a shortened lifespan. Like all-cause mortality increases, which is a pretty severe thing, but it's true. That's why we don't do it. That's why we don't remove ovaries on women very early. You shouldn't anyway, but even more so, we know it's a problem. So that's why it's very tricky. Endometriosis is a very tricky thing because just removing ovaries doesn't necessarily blunt it entirely. And then you have menopausal symptoms. You have other problems, especially then if you want future fertility. So it's a tricky disease. It's still something that it very much remains a problem. So that's the role of GnRH agonists, which is really Lupron, as selective preoperative therapy, and then also for complicated endometriosis, cycles of it. If you are interested in that, as a fourth year, I would recommend if you can get a rotation at a endometriosis center of excellence. If you meet these patients, what they'll tell you is that they're very knowledgeable of their disease. It's very nuanced. Sometimes they'll be on periods of Lupron and they'll give them a drug holiday. You'll see that the newer medicine, the GnRH antagonists, they can be on that for a certain number of years. It's like 1 to 2 years, and then the disease will almost rebound, kind of like how cancer does, and it'll come back and it'll be resistant, or side effects will occur in that interval. It's very interesting, but it's a highly nuanced disease, and that's why there are specialists who just do that. Usually, your minimally invasive people, they will be the type to manage this. Like if you go into a minimally invasive fellowship after you do your OBGYN training, you're very much, you often become an endometriosis specialist, and that's the sort of role you take. So with other medical treatments, then you have your antifibrinolytic agents, which don't have anything to do with the uterus proper or the GYN unit. It really just has to do with the coagulation cascade, in that it prevents plasminogen from becoming plasmin, and then it interferes with the clotting cascade. Tranexamic acid is actually FDA approved for the treatment of heavy menstrual bleeding. It's indicated for use during the 5 days of the actual period. So you kind of have to have normal menstrual cycles to use it. It wasn't studied specifically with fibroids, but it was some women had fibroids in the study. They say like 35% of the women enrolled in the trial had fibroids, which is kind of like a shoddy mechanism, but it is what it is. And it does help actually. But it often doesn't take it away, and it does nothing for the pain symptoms. The heavy bleeding it does. Oftentimes it's kind of used in that preoperative approach when you have a patient and you want to kind of get them optimized for surgery, because oftentimes they're severely anemic, right? Yeah, you'll give them blood transfusion, but then by the time of booking and things like that, they're still bleeding. You want to make sure you mobilize their blood, their iron stores as much as possible. So you tell them to take this in the 5 days when they actually do have a period, and that actually helps quite a bit. And then, but the mainstay beyond that is surgical management. And we speak about alternatives to hysterectomy, though ultimately hysterectomy is the most definitive treatment. Sometimes your strategy, if you don't want to do a hysterectomy, which sometimes women don't want that, and oftentimes it's not best to just jump to hysterectomy. What you could do is basically try to time it so that, especially if a woman is closer to the average age of menopause, which is 52, you can essentially bide your time until they hit menopause. And then because these things are estrogen responsive, as evidenced by, just what is known foundationally, but also I told you that with Lupron, it really works because you put them into menopause. You can use your alternatives to hysterectomy there. If you remember nothing else about them, know that all of them have about a 5-year success that they grant you on average. Some less, some more, but generally 5 years is what you anticipate. And that's what you tell your patient. Otherwise, there's a risk of recurrence with them. Endometrial ablation is a procedure where you use radio frequency ablative techniques to essentially cauterize the endometrium. So the end part of where you were bleeding is now longer functional, okay? It can be effective on that basis, but really it's just because if you have submucous myomas, that's helpful. But there's an asterisk here because the NovaSure system is really the only FDA-approved non-resectoscopic endometrial ablation, and you can't use the resectoscopic ablative techniques anymore because they were recalled. Okay, this one used radio frequency ablation. There were other ones where it was called a thermochoice, were actually used as an intern, was that you basically filled up this membrane with extremely hot water, and that would cauterize the endometrium. So even if there was a myoma in the endometrium, it really didn't matter because it would cauterize, it would go around it. But this NovaSure system, as you can see in this picture, it's a flat membrane that extends. So if you have a myoma there, it's not going to work because it's just going to be dislodged. That's why this thermochoice, the thermal balloon, which I just said, the heated free fluid, it's not really used anymore because what was happening is it was causing problems with leakage and spillage, and other parts were being burned, etc. But the bottom line is the one that we do use, but there's the NovaSure. That may vary across the country. I will say in New York City that this is the case. I don't know that for a fact. But the satisfaction rate is pretty high, and the success diary for 75, they rated it by a score of 75 or less was the success. It's pretty good. But that being said, I had a patient the other day that I did a laparoscopic assisted vaginal hysterectomy because she had a endometrial ablation 4 years ago, and she was still bleeding, still having pain. She's like, I'm done. So we did that, and now she's very happy. That's pretty much it. So another technique is called uterine artery embolization, which is a a really good option if a patient is a poor surgical candidate, because what happens is that interventional radiologists do this, and they pass a catheter through the iliac arteries, which you see here, and they contact our uterine artery, which is here, and then the perforators to the uterine corpus proper are embolized, and they can do selective embolization and basically starve off the blood supply to the myoma. It will degrade, and then you're done. Okay, and it's done through a catheter, and it could work. Now, the problem with this is similar to endometrial ablation is that your fertility potential is unknown at best and eliminated at worst. So they'll tell you that fertility has not been well studied. The ones that have studied it have linked an increased obstetrical outcomes, as you might imagine, which includes higher miscarriage rates and more likely to have cesarean deliveries and postpartum hemorrhage, because you're impairing the uterine body. You're basically starving it of blood supply, and that while it's as selective as possible, it's still causing some damage to the uterine corpus. There's a big study, a randomized trial that everybody was excited about, that compared embolization to total abdominal hysterectomy, and it showed what you might expect, is that there was increased in the first 24 hours. I mean, a decrease in pain post-operatively or post-procedurally in the case of the uterine artery embolization, but there were increase in minor complications like the hematoma formation and readmission rates. Really is the thing you want to look at. Basically 11% versus none for a total abdominal hysterectomy, because you still have pain, you get a fever in the first 24 hours. I mean, because you still have a uterus that has to heal itself now. So that's why it makes sense on that basis. It's an option that exists for, like I said, for poor surgical candidates. And more importantly, if you could appreciate this image again, it really works best if you have multiple intramural fibroids that aren't that big. If you have a uterus that has a bunch of pedunculated subserosal fibroids, for example, right? Uterine artery embolization is not going to help you all that much. Also, say this is a cavity. Say if you have big fibroids, right? Fibroids are parasitic, so they're going to recruit blood vessels from everywhere. If you do a uterine artery embolization, this is less likely to be successful. You're probably just going to starve the corpus itself rather than these big fibroids, which you're going to find as blood supply elsewhere. So you also have to stratify your patient and your treatments based upon, really, if you're talking about fibroids, looking at the subclassification system. Where are they? Is it even going to work? Okay. It's not really acceptable to say, oh, let's just try it. Because if you do an endometrial ablation, I mean, if you do a uterine artery embolization and it fails, you got to wait. That's more time for the patient. And then when you go to do your hysterectomy or myomectomy, it's going to be much harder because there's usually fibrosis and scarring and all because of the insult that you provided. So you have to pick your patients carefully. Now, if we're talking about myomectomy, which means you're removing the fibroids with preserving the corpus itself. This is the main technique used for those who desire uterine preservation. Okay, generally it's not a preferred treatment for someone who's postmenopausal and can't have children, but women don't necessarily want their uterus removed. Okay, so there's a couple of different ways you can do it, and it really depends on where the fibroids are. It always comes back to that. Hysteroscopic, vaginal, abdominal, or laparoscopic, okay? Your abdominal myomectomy is usually for, I think that's probably the best treatment if you have large fibroids that aren't exclusively submucosal. But again, you have to consider whether a second procedure is still going to be needed after conservative surgery. What that means is that if I do, like, what's your goal? Because an abdominal myomectomy most certainly will mean that you need another surgery, especially if you're a younger woman, and by younger I mean less than 40. So most women, this is a specific study, but the trend is the same for pretty much every situation you could think of. Women who have multiple fibroids, about more than half of them experience recurrent myomas, okay? And about 26% of those, so say about a third of them, more or less, required another procedure. And that's the trend. Similarly, if you do this procedure closer to menopause, you may get away with it without having to do a hysterectomy if that's in line with the patient's goals. If you have someone who desires fertility but has a bunch of large myomas that otherwise would obstruct that process or make it a high risk pregnancy, for which large myomas during pregnancy are, doing this procedure and waiting about an appropriate time for the uterus to heal, and then attempting pregnancy, getting pregnant, having your deliveries, and then perhaps thereafter, which is what, a couple of years, scheduling a hysterectomy, not a bad plan, okay? An abdominal myomectomy is what you might imagine. It's usually done with a low transverse incision and the uterus is elevated. This is actually for a hysterectomy with the clamp and the neck set, but the point is you exteriorize the uterus and then the fibroids are removed. And if you have a big fibroid compared to the uterus here, that's the desirable treatment. Laparoscopic or robotic assisted surgeries are pretty much the same thing. It really depends on if you're able to access all of the fibroids laparoscopically or robotically assisted. It really depends on your operator, but it's the same. The improvement is the same to a similar degree. Just FYI, your conventional straight stick laparoscopy is done with 3 to 4 ports. If you see me do these procedures, what you'll find is that I'll do one in the left upper quadrant, and then I'll have incisions here, here, and here. I usually don't do this one here. Robotic is more incisions. It's about 5, and they're a bit larger, but this is just counseling of the patient as well, just what to expect. Hysteroscopic myomectomies are done if you have only submucosal leiomyomas, because the type 0. Okay, one moment. So if you have exclusively submucosal myomas, you can use a procedure called hysteroscopic myomectomy, that essentially you have your uterine cavity, you have your myomas here. You could use an instrument called a MyoSure. That's a trade name. There's other ones, but this is the better one. And it will sequentially eat up this fibroid, and then you're done. I had a video, but I guess it doesn't work. And hysterectomy is ultimately the definitive treatment. There are minimally invasive techniques such as vaginal or laparoscopic assisted vaginal, which I do a lot of. Robotic assisted, which is the same as laparoscopic, just using a robot to help you. And that's when you remove the hysterectomy refers to removal of the corpus, right? If it's a total hysterectomy, that means you're getting rid of the corpus and the cervix. A hysterectomy has nothing to do with the fallopian tubes or the ovaries. That's why if you see a procedure described, it'll say a total abdominal hysterectomy, bilateral salpingectomy, right? They have to say that because it's not the same thing. And then the root doesn't change the fact it's still a total hysterectomy. You get a total vaginal hysterectomy, you're gonna have a total laparoscopic hysterectomy, a laparoscopic assisted vaginal hysterectomy, etc. Okay. If you can do it minimally invasive, it's preferred because it makes it an ambulatory procedure, meaning that they go home the same day, and the short-term outcomes are better as opposed to an admission for a laparotomy. But if you need to do a laparotomy based upon the uterine size or complexity, there's nothing wrong with that. You should just do what's most appropriate. Okay, so ovulatory dysfunction now has to do with when you have bleeding that is independent of your uterine corpus in terms of it having any structural problems or not. It's a wide spectrum disorder, but it causes heavy irregular bleeding. Irregular. That is the most important thing. If you go back to that slide I showed you in the beginning, your question about the regularity of the menstrual cycle will tell you your answers. If you're having a question, it'll tell you if there's regular cycles or not. It has to. So that is the main way you're going to know. And I already mentioned that the effects of unopposed estrogen on the endometrium is why you have abnormal bleeding in the setting of ovulatory dysfunction. This is like the most key concept I can tell you. Remember it. And then your hypothalamic pituitary ovarian axis is its modulator. As such, the reasons why it may just be adolescence or menopause, meaning that adolescence and menopause are similar in that they're states where you don't have estrogen, okay? I mean, you don't have menstrual cycles. So you may have estrogen exposure on that basis without progesterone, so it's the same thing, okay? Lactation can cause an irregular menstrual cycle, but it does not preclude you from getting pregnant. I had a patient who was breastfeeding after a vaginal delivery, and then she stopped having a period. And then she said, oh, I don't know, I haven't had my period. And then we said, oh, let's just do a pregnancy test, and came back positive. And she's like, I didn't think I could get pregnant. Well, you can. She was pissed. But just know that. And obviously, would you have to check if a patient is having amenorrhea, say, you got to check if they're pregnant. So those are physiologic reasons for irregular cycles. And we're talking about ovulatory dysfunction. So AUBO. You're looking for endocrine problems. You're looking for HPO axis problems. So medications, especially antipsychotics, can cause menstrual irregularities. Thyroid disease, hyperprolactinemia. And if you have a prolactinoma, you want to go get your MRI of the head to make sure that you don't have if you have hyperprolactinemia, you want to rule out prolactinoma. So you got to get an MRI of the head. Hypothalamic dysfunction, like anorexia nervosa, but also, your female athlete triad, that's actually a real thing because it disrupts the HPO axis. So then you can have problems there as well. And then you could just have good old premature ovarian failure, which is an idiopathic situation, but you could diagnose it. You diagnose it with something called obviously your history, but anti-Müllerian hormone, okay? And if that value is really low, then your ovarian reserve is low, meaning that it's just not functioning. And then also you look for your hormones like estradiol, FSH, LH, and what you'll find is that in those patients, they're about, in their 30s or whatever, their values will be very high, resembling menopause. Because in your menstrual cycle, because the ovary is not cycling, those values just they increase to high levels. Things like PCOS, polycystic ovarian syndrome, other more endocrine specific ones like congenital adrenal hyperplasia, all of this can cause a disruption of your APO axis and as such AUBO. Okay. This is something really important to know. So in your menstrual cycle, so I'll review it again. In your normal menstrual cycle, in your proliferative phase, there's a peak of your estrogen. And then ovulation happens around 14 days. And then your secretory phase, estrogen goes down, and your progesterone will go up. And then because you're not pregnant, I should say, this will go down. So if your ovary is not cycling properly, what you have is you'll pretty much have opposed estrogen because, I told you can get it from E1 in the periphery, and also the estrogen that is being made when it's the case. So what happens is that this is jerky. So you pretty much have unopposed estrogen, and then this endometrium is in different stages of development. It doesn't have this smooth grow. Estrogen will grow your endometrium, okay? But it won't stabilize it. Progesterone is your stabilizer, and that's why it's used in your levonorgestrel IUD, or even if you have a patient in the ER and you say, okay, then you'll hear the resident say, oh, give her Provera and it'll be fine. Well, is it appropriate? Because it's just striking that balance, as I mentioned with the levonorgestrel system. So if you have a situation where you're growing and growing and growing and growing and growing, it's going to outlive its blood supply, then it's going to slough. But because you're in different stages of growing, this is going to eventually slough, and you're sloughing here, and that equals heavy menstrual bleeding, or really abnormal uterine bleeding, right? That's why it's heavy. Okay, that's why it's heavy, because it just continues, and then to stop it is tough. How do you do that? You basically got to get rid of this redundant tissue and then strike your balance back. You can strike your balance back by controlling the hormones that are there with things like oral contraceptive pills. But ultimately, sometimes what you'll need to do is to do a dilation and curettage to kind of start at a baseline. Okay, that's your strategy. That's why you'll see patients who have ovulatory dysfunction, well, we book them for D&C, and you say, well, why are you doing that? There's not a structural problem. But there is, in a way, because of your abnormal endometrium. But for the purposes of what you have to understand at this stage of the game is that abnormal uterine bleeding causes a problem because you have an imbalance between your estrogen and your progesterone. And that has an effect on your endometrium being overgrown and unstable, and it can slough at different points. In your menstrual cycle, you also have an interplay with inhibin B and inhibin A, and sometimes they like to ask you that. Do you remember where you see inhibin B besides this context? It's a tumor marker for granulosa cell tumors. Granulosa cell tumors will produce inhibin B. That's a tumor marker. It's a germ cell tumor. It happens in young women. You also see something called a calyx in your body. Okay. You'll also inhibin A. Where do you see inhibin A in OBGYN other than this? You see inhibin A in your prenatal screening, right? You see it in your quad screen. Because certain aneuploidies are associated with a change in inhibin A. So from here, you can make your age-based differentials diagnosis. And actually, this is something that is a benefit, because you can stratify your differential diagnosis largely based upon a patient's age, really just because it's when they have exposure to estrogen or not, because it's really an estrogen thing. So from 13 to 18 years old, abnormal uterine bleeding is usually because of persistent anovulation. Either a woman hasn't had a period yet, which is really just a normal consequence of immaturity, as I mentioned before. But also here, you want to consider abnormal uterine bleeding also because that's when women are starting to use hormonal contraception. And if that's not consistent, say they start birth control pills, stop it, start it, stop it, you pretty much have ovulatory dysfunction, don't you? Because this, oh boy, that looks a little dirty. The point is that this balance is you're having irregular hormone cycles, even though it's artificial, right? So you have to think of it that way. Obviously, you have to rule out pregnancy, okay? But pelvic infections like STDs and stuff like that, this is prevalent among this age group, and that can cause abnormal uterine bleeding in that regard too. 19 to 39, this is pretty much all comers, but this is where fibroids come into play. Now that you have had estrogen on board for a while, polyps and fibroids can grow. In the 13 to 18 age group, you haven't really had enough estrogen to develop fibroids, unless you have someone who's morbidly obese at a young age, then you can do it. PCOS starts to become a problem if it's present, And endometrial hyperplasia is a consideration, but usually only if somebody's morbidly obese, because you have so much estrogen E1 on board, it can cause hyperplasia. Other than that, it's very rare in this age group because it's just not commonly seen in younger women. Endometrial cancer is a disease of older women, just because it's consistent unopposed estrogen. So you more or less need time. But if you have that peripherally, you may have that. I had a patient, she's 19 years old, and she had very bad PCOS. And one of her manifestations, obesity is not part of it, but oftentimes is associated with metabolic syndrome. She had a BMI that was greater than 40, and I ended up taking her for dilation and curettage for the same logic as I mentioned to you, and she already had simple hyperplasia without atypia, but to have it at 19 years old is not a good thing. We had to work pretty hard to get her under control. From 40 years to menopause, same thing, with the exception that endometrial hyperplasia comes into play a bit more. And if fibroids are troublesome or resistant to treatment, this is when you start to see it. And this is why hysterectomies start to happen at this age. This is a flow sheet that OBGYNs love so much, but it basically is what we all spoke about. Managing ovulatory dysfunction, it's mainly a medical treatment thing. You have to strike that balance. Now, obviously, you have to correct any endocrine abnormality, say there's a thyroid problem, which is usually hypothyroid, but if there's prolactinoma, what have you. But if we're talking about strictly ovulatory dysfunction, your progestin-only therapies are used, because I said before, like you strike a balance. Those include your intrauterine system. Majestic progesterone, acetate, megestrol, and norethindrone, these are oral pills, okay? And then your depo-medroxyprogesterone acetate is your IM injection. But it's the same thing, it's the same concept. Combined hormonal contraception is estrogen. EE is what's abbreviated because it's estradiol, because it's two, right? And then a progesterone. There's different formulations of progesterone and it has to do with their structure. So if you have something called, say, levonorgestrel, it's a different formulation than norethindrone. You see the drone, so you're more of a steroid component, as opposed to levonorgestrel, which is a different sort of progesterone. It doesn't really matter for the context of what you need to know. When you get into it a bit more specifically, if you're an OBGYN, it actually does matter quite a bit. But estrogen, the combined hormonal contraceptives, which include estrogen, include patches, the vaginal ring, which is NuvaRing, or just your PO medications, right? And this is actually probably one of the best sort of options you have. The bottom line is that the approach is that it thins the endometrium or provides a balance or protects it from hyperplastic transition. And that is what you want to achieve first and foremost. There are different phases. You'll hear phasics, right? That's sometimes confusing. So monophasic, biphasic, triphasic, quadriphasic, what does it all mean? But if you look at the menstrual cycle, you see something that looks like this, right? It's not one line. That's what a monophasic is. The examples are, they're all ethinyl estradiol plus the progesterone, as I mentioned. So they're all EE. So this one is just spironone, which is called Yaz, or norethindrone, which is low estrogen. It delivers the same amount of estrogen and progesterone per each pack. Then people came along and they said, well, it shouldn't really be like that because that's not what the menstrual cycle is like. So there are biphasics that go into two. So you have pretty much a response like this, right? Well, actually, it's more like, and like that. There's triphasics that divide it even further. It's like 1, 2, 3. It doesn't always increase. In fact, actually, I think what's more appropriate to show is actually it decreases if you look into it. So what's normal is like this, because it ends up being, say, that's 1, 2, and 3. For estrogen, and then the progesterone looks like this. And then triphasic and then quadriphasic. But they're all the same in terms of their effectiveness and it doesn't really matter which one you pick. Even if you ask the family planning specialists, which are the ones who know this physiology best, they say it doesn't matter. And usually just one that the only consideration in the different estrogen pills is that if you're dealing with an endocrine problem as well, specifically, it behooves you, especially like in PCOS, it behooves you to do more of a steroid combination like drospirenone, like the nones, as opposed to your acetates. I mean, your not acetates, your like your norgestimate, right? Or gestrel. It's just the structure of the steroid is what you want. So where the evidence is comes from is actually very limited. There's an RCT and meta-analysis looking at the levonorgestrel IUD, and that helped. And then also, if you're looking at I mentioned there was a bunch of different phasic medicines. The one that they studied and has actually been in an RCT and helps with AUBO is a triphasic, okay? So if you're a scientist like myself, you would say, well, if the triphasic was studied, behooves me to use the triphasic, doesn't it, right? And that's not always covered by insurance. But this is where the evidence is, just FYI. And so you could stick with the levonorgestrel, the Mirena, or your triphasic. So in terms of treatments, for younger women, combined hormonal oral contraceptive is best, based upon what we discussed. For 19 to 39, it's probably better to give the IUD a try if it's AUBO. Heavy menstrual bleeding like that is leading to unstable, a patient instability due to anemia, you can treat them with high dose estrogen therapy briefly, and that will quickly stabilize the endometrium to prevent further blood loss to avoid an acute event like an MI, okay? And then 40 years old, you could pretty much use either. If a woman doesn't want an IUD, you could try low-dose oral contraceptive pills. But your menopausal symptoms, if that's in play, that requires its own treatment. When you're talking about endometrial hyperplasia, it's when you have unopposed estrogen to the point where that the endometrium itself begins to undergo some sort of atypical change. You can have precancerous changes, which extend from it. Well, it depends on the classification system. You have the World Health Organization classification, and then you have endometrial intraepithelial neoplasia system. The bottom line is that chronic unopposed estrogen stimulates your endometrial hyperplasia because you don't have the balancing effect of progesterone. That's why it happens in older women, because they're in menopause. But other situations can cause it as well. The World Health Organization basically will say normal endometrium, you could have simple hyperplasia. And then hyperplasia is just the amount of cells, right? So the way that they classify it is simple, meaning there's not that many increase in cell. Complex means that there's a lot, but the bottom line is your atypia, okay? If you have atypia, that means that you have increased components in the nucleus and the nucleolus of your cell, which means that it's making itself bigger in a way that's abnormal. It's actually growing more, which is abnormal. So you see your chromatin could be clumped, and the nucleoli themselves, not only is there kind of like clumping of it, but they're big, right? That's what atypia is, and that's bad. And gland crowding, lining by the atypical cells, is your hallmark sign for endometrial intraepithelial neoplasia, if they ask you that. But basically, the atypia is the problem. The endometrial epithelial neoplasia classification is a different system that you may hear, and it's a little bit easier in that it's either benign or it's intraepithelial neoplasia, kind of like how you'll have with the cervical cancer screening, like cervical intraepithelial neoplasia, but this is just like it's either it's benign or it's not, okay? It's either an endometrial precancer or it's not. And ACOG says you can use either, even though the World Health Organization remains more widely used. if you have complex atypical hyperplasia, you're looking at a background risk of endometrial cancer about 40%. You can estimate that on your exam. Okay. The highest risks are atypical hyperplasia, complex atypical hyperplasia, which I just mentioned, or if you have endocrine into epithelial neoplasia, because it's either that or nothing. They have the most significant risk. You want to get an endometrial biopsy or do a DNC to get a sample to rule out carcinoma. So those are the highlights of what you need to know. I would go as far as say, if you understand everything in this lecture, you pretty much have abnormal uterine bleeding set, and you pretty much have gynecology set, as opposed to other select topics like PCOS or endometriosis. But what I would focus on for those is very much just their diagnosis, because that's what they could test. Other than that, it's very selective. So PCOS, you want to think of your Rotterdam criteria, which includes 2 of 3 symptoms. Either you have clinical hirsutism, meaning abnormal hair growth, or you could have laboratory results of that, meaning increased total testosterone. You have to have some ovulatory dysfunction is another category. So what I just mentioned before with the hirsutism, clinical or laboratory is 1. 2, ovulatory dysfunction. Or 3, you can have, if you have hirsutism and increased total testosterone, that would be that you can count that as 1 or 2. So then you would have that's your Rotterdam criteria. If you have 2 out of the 3, that's it. Okay. Then endometriosis is obviously the way that you do definitive treatment of endometriosis. You have to do a laparoscopy and get a sample. You can presumptively treat it, but ultimately that's how you do an official diagnosis. Okay. So, are there any questions? I know most people had to run.